Now I will be speaking on important aspects of diabetes mellitus. It is of two types. Type 1, in which there is autoimmune involvement of pancreas, and type 2 diabetes is seen in middle-aged persons and has some element of insulin resistance. Classical symptoms of diabetes are polyphagia, polydipsia, and polyuria, but are not necessarily present. Symptoms which arouse suspicion are delay in healing of wounds and infections, angina, vision loss, neurological symptoms, and renal failure due to complications. Acute complications like diabetic ketoacidosis can be a presenting picture. Diabetes can be diagnosed by fasting blood glucose, and values greater than 126 mg per deciliter are diabetic. 110 to 126 is pre-diabetic. ppbs 2 hours after 75 gram of glucose, if greater than 200 mg per deciliter, is considered diabetic, and 140 to 200 is pre-diabetic. HbA1c level greater than 6.5% is diabetic. Management includes dietary restrictions like avoiding sugar. Obese patients should increase exercise and reduce weight. Drugs used are metformin, which reduces hepatic glucose production and does not cause hypoglycemia. Initially, metformin should be given, but if proper control is not achieved, then add sulfonylureas like glimepiride. They increase insulin secretion by pancreas and sometimes may cause hypoglycemia. If still proper control is not achieved, add DPP-4 inhibitors like vildagliptin. They do not cause hypoglycemia because they increase insulin secretion when there is a glucose trigger for it. Sometimes voglibose is also used to control postprandial blood sugar, as they delay carbohydrate absorption in gut. Pioglitazone enhances the action of endogenous insulin, but there are reports of side effects like bladder cancer, and so it is avoided nowadays. SGLT2 inhibitors like empagliflozin increases glucose excretion in urine and may cause genital fungal infections, but reports of less cardiovascular complications in patients using it are encouraging. Insulin is the last resort when oral drugs fail to control blood sugar, and it is many times required in type 1 diabetes. Combinations of fast-acting insulin like actrapid and intermediate-acting insulin like isophane and lente are required. In diabetic ketoacidosis, soluble insulin is used IV and normal saline is given IV to manage fluid loss. There is usually hypokalemia, and so IV potassium is given and blood potassium is monitored regularly. Thank you.